Management of subluxated LASIK flap. Flap subluxation is a serious but manageable immediate complication of LASIK surgery. Most common cause is due to mechanical trauma. We had a patient with complaint of pain and watering on post-op day 1 of an uneventful LASIK surgery. This is a clinical picture of the same patient. We can clearly see the subluxated margin which is in the supratemporal quadrant. Under topical anesthesia with 0.5% paracaine, stromal bed was thoroughly cleaned with hypotonic saline. After replacement of the flap was also cleaned thoroughly and all the edges were cleaned nicely. All of the loose epithelium was debribed carefully with a forceps. Care should be taken that there shouldn't be any undue force on the flap and the underlying tissue should be delicately handled. Ironing is performed. This is the main step of the treatment, and ironing should be performed preferably with a half wet Neurocell sponge in the direction starting from the hinge going opposite. This hinge gives a counter traction to the force and prevents any further movement of the flap while ironing. After every maneuver, carefully debride all the loose epithelium and clean your flap repeatedly. Remove any loose epithelium present over the hinge. Ironing can be performed with two Neurocell sponges, one stabilizing the flap and other used to iron. Ironing is also to be performed in the direction perpendicular to the stria so as to flatten out and reduce the stria. For debridement of the loose epithelium, you can either use a forceps or a scorer, or even with a dry Neurocell sponge you can debride the epithelium very easily. Once you are satisfied with the result, apply antibiotic soaked BCL carefully without leaving any air pocket. Leave the eye open for 2 minutes and let the lens settle, and do check the stability of the lens. These are the preoperative pictures where we can see the supratemporal margin being subluxated, and after 1 month of treatment the flap has nicely been taken up and there are no stria or any haze in the interface or in the flap. Patient had a good visual acuity of unaided 612 and with one cylinder of 6.6. So the take home message is, advise your patient to use eye guard at least at night, because there could be involuntary rubbing of the eyes during sleep. As soon as diagnosed, make no delay in treating and repositioning the flap. Reassure the patient, which is very important. Debride any loose epithelium which has grown over the edge of the flap and hinges. Use hypotonic solution for irrigation as it leads to swelling up of the flap and flattening of the folds. Iron the flap in direction of against the hinge and also perpendicular to the fold. At the end, apply antibiotic sold BCL and keep a very keen follow-up afterwards.